officially starting our December 19th PEB board meeting. And I'm going to do a roll call. I know we've got a couple people joining from their phones, so I'm not sure who all is here. I can see some of you. So Dawn, are you here yet? Dawn Mottner.
Yes, ma'am. Good morning, present.
Great. Good morning. All right, Greg, I can see you. So I know you're here. And Chicky is joining us by phone for the beginning of the meeting. Chicky, are you here yet? All right, I'll check in again to see if Chicky's here. Andy, I can see you. Good morning. Kimberly, I can see you. Good morning.
Good morning.
Oh, Chicky, there you are. You actually, you're on video. I know I heard you were driving, so welcome. And Emily, I thought I just saw you. There you are. Good morning, Emily.
Good morning.
And Representative Notes, I see you as well. Everybody is here. Welcome. So our first order of business this morning is to do the minutes from our November meeting. Hoping that I have someone ready to put a motion forward around our minutes. Do I have anyone who would like to put a motion forward to approve the minutes?
I can motion that we approve it.
Great,
Or
thanks,
second.
Greg. And Chicky, are you seconding for us?
I will second for the team.
Okay, thanks so much. All right, Dawn, how do you vote on the minutes?
Approve as written.
Great. Greg's our first, Chicky's our second. Andy, how do you vote?
I approve.
Okay, Kimberly?
Approve.
Emily?
Approve.
Great. Thanks, everyone. So our minutes are approved. And we have another action item next. I believe April Kelly. April should be here with us, and she's bringing back a decision that we discussed earlier in the fall. So April, go ahead.
Yes, thank you so much. Good morning, everybody. Can everybody hear me?
Yes.
Okay, I lost power and then I got it, and yes, it's been fun. But I'm April Kelly, and I'm the PEB and OEB Rules Coordinator, and I am here to talk about Attachment 2, which is on your screen. And I think page 7 in the packet if you have it physically printed out. But back in the fall at your October 17th, 2023 board retreat, I brought you some rules and requested your approval to take these rules through the permanent rulemaking process. And you all approved me to do that. And so we did file the notice with the Secretary of State's office. We sent them out to interested parties. These rules were open for public comment all through November, and we held a rules hearing. We had a few attendees, but we didn't receive any public comments. So if you remember from October, these rules are for the administration of the SB 551 program. So for the self-pay or partially self-pay employees with higher education and their benefits. And we really, prior to even bringing these to you in October, we really worked with, we had a pretty robust rules advisory committee. We worked with DOJ, we worked internally. And so we don't have any changes to these rules. These are the exact same rules that we brought you back in October. And so I'm here after going through the entire process, and I'm back and asking for your approval to file these amended changes permanent with the Secretary of State's office.
All right, thanks, April. And I know we've discussed this on the board when it was initially coming about, that this allows people access to the health care that they should be having access to when they are moving between higher education institutions. So do I have a motion to accept the permanent rule change?
I will make a motion to accept the permanent rule change.
Thank you, Andy. And do I have a second?
I can second. Greg Close.
Thanks, Greg. All right. So Dawn, how do you vote?
Approve.
Thank you. And Chicky, how do you vote?
I approve.
Kimberly, how do you vote?
Approve.
Emily, how do you vote?
Approve.
All right. Thanks, everyone. So this goes into permanent rulemaking. Thank you, April.
Thank you. Appreciate your time.
Yeah. All right, so
Thank you, April.
Thank you.
yeah, I know a lot
thank
of
you.
people will appreciate this for sure. All right, so we are moving back to our discussion of pharmaceuticals as announced in November. We have the Kaiser presentation today. We heard from Providence and Moda in November, and Kaiser's rounding us out. We should have Dr. Keith Bachman with us, as well as Sunshine Summers. So I'm going to hand it over to the two of you. You both here?
Good morning.
Good morning. Is Dr. Bachman on? Is he joining?
I believe so. There he is.
Okay, great.
Apologies, I was getting some water there.
Yep, no worries. I'll leave it over to the two of you.
Great. Thank you guys for having us today. We really thank you to the board and the staff for allowing us to present our pharmacy program. And we have a very full conversation today about how we manage pharmaceuticals, both to aim for highest quality and optimize costs. So we'll be presenting some data. We'll be talking about our principles. We'll be talking really about how we do the work that we do. I'm pleased to be presenting along with Sunshine Summer, who's our director of pharmacy, of clinical pharmacy. So we kind of went through, we were asked to respond to some specific things, and we will do that. It was noted among all carriers, there were three main classes that were driving growth. One was immunosuppressants, the other one was molecular targeted therapy, and the third one was diabetes drugs. We found a little bit different looking at our own data. We found that the anti-inflammatories, which included both immunodermatology drugs and anti-inflammatories, were, like with all carriers, the highest cost drivers with a $14 PMPM for that. Our second one was actually respiratory, which was $7.96 PMPM, which is accounted by a handful of members with CF, with cystic fibrosis, which requires highly effective but highly expensive therapy on a chronic basis. And then infection was a little bit less than $5, which was primarily anti-HIV treatments, including PrEP. And then the fourth most common one was diabetes at $4.20. We also found a driver from last year to this year is vaccines, which are actually included in medical pharmacy, and that number is increasing year by year. So we'll be talking about our three main ways that we're achieving our outcomes, which is in terms of drug management, channel management, and then finally member support and outcomes monitoring. Next slide, please. Just wanted to get to kind of an overview of the economic bottom line, and how we're reading this is that you have the 4 or 5 main categories of drugs in the rows, and that's generic drug, brand preferred, brand non-preferred, specialty medications, and then a combination of all those. And then below is the medical prescription, which is infused medications, which can be anti-inflammatories, vaccines, as well as cancer chemotherapies are the bulk of those. But just looking at the overall PMPM change from last year, you can actually see good news in the Kaiser Permanente membership and pharmacy system, with a reduction in dollars per member per month of 59 cents, comparing total year 2022 with the first 10 months of 2023. You can see a 59% reduction. You're comparing the prior PMPM to the current PMPM, and you're kind of then by row, you're seeing how that is related to utilization impact, which is just prescriptions per 1,000, unit cost, what is the cost for each prescription, and where possible, where we're able to, as new products come on the market or new products go generic, we're able to substitute a less expensive medicine for a more expensive medicine. Little different patterns into those. I won't go through those. I just want to report the overall, the being able to manage the costs of our generic drugs and preferred drugs. We're able to keep that overall PMPM down. So we'll go through a little bit more details about drugs by classes. Next slide, please. So it's a whole system, and everybody, many parts of the company and the health delivery system are playing a role. And what's unique about us is it is integrated. The medical care program and the pharmacy care program are really one and the same. And you really can't pull those apart. I know there's been discussions would it be more efficient to have all OEB and PEBB members and OEB members all involved in the Oregon or the prescription management program. But for us, that doesn't work. It would really be bad for customer service. It would be bad for costs. And what we do is unique. Multiple parts of this, and we don't need to go through all these in detail, but really what's important is our ability to purchase strategically, have a benefit design that's efficient and gets medications that are most cost effective and most effective to members at the most appropriate recommendation, a formulary system that's integrated into that. That's a close partnership with the medical group and the pharmacy group, building that formulary into our electronic medical record, providing in real-time decision support. So basically, if another drug has come on that is more favored due to effectiveness or cost, the system will help guide me to that appropriate medication. When the recommendations for most infections went from 10 days of antibiotics to 5 days of antibiotics, recognizing decreased side effects, decreased costs, and similar efficacy, we were able to make those changes fairly quickly. And it's a basic example. Or similarly, when a biosimilar comes on the market, we're able to quickly put that into our protocol. So that's now first therapy. Now I can always go around that. This is not quick medicine. I'm not required to use it. If medically necessary, if there's a reason, if someone has tried it and has failed, I can always choose a different medication that will be less preferred, likely higher, more expensive to the plan, likely more expensive to the member. But again, I'm in control of that, but I work here, my colleagues work here to provide the most efficient, cost-effective, and medically effective care. Little icon there with the pill box there on the lower left. I know I'm not going in a very good order here. Is really that this is all we're able to dispense. Our pharmacists in our retail pharmacies can do education. Our pharmacists in our mail order pharmacy can do education. And we have pharmacies embedded in our pharmacy utilization intensive programs that can also do education. That would include rheumatology, HIV care, hepatitis C care, oncology care. And so that's in real time in the medical offices, phone context. Pharmacists are embedded in our case management programs, working for diabetes, working side by side with nurses. So I think that's kind of the overall cycle that we have. This is an integrated system. It works because all the parts work together and there's a high level of coordination between these parts, which leads to both a positive member experience as well as our ability to manage costs appropriately. Next slide, please. Again, this is just what I said. Our PBM is the same as our company. We're getting away from those complicated relationships. The rebates affecting care. Yes, we'll take rebates but we're trying to avoid contracts with rebates and trying to really be most efficient with that. So I would just want a little bit fine print there at the bottom. It just talks about the accolades for our pharmacy program. So we have received the Pharmacy Quality Alliance's Excellence in Quality for the past 12 years, which is no easy feat. Next slide, please. This just acknowledges the volume. So it's 640,000 members in the Northwest, but 12 million members nationally. And that allows us to purchase medications at bulk, so we get the great prices on generic medications. It also allows us to develop expertise. So in the more rare conditions, some of the cancer conditions, immunologic conditions that are rare, expensive, as we're deploying genetic medicines, we can have national experts work with us, and each regional expert kind of connecting with their national counterparts, coming up with how to do it. We'll talk a little bit. We could spend an hour talking about oncology, and we're not going to do that, but really that's very much embedded in our oncology program. The scale and the expertise and the development of, both adopting the national NCI and NCCN guidelines, but also seeing internally what's working and using that data to adjust the algorithms when necessary. Next slide, please. Okay, I will now pass this over to Sunshine. I think we're on slide 7 and 8.
Yeah, good morning, everybody. Thanks for having us. I'm going to talk a little bit about our formulary management program and kind of some tactics we use to make sure we're managing medications appropriately. So first of all, starting with our overall formulary strategy, Dr. Bachman kind of covered some of this, but we are partnering with our physicians in an integrated way to make sure that we are scanning always for approvals, new warnings about medications, and updated guidelines. And then we have internal P&T committees that we have physician and pharmacists voting members, and we review evidence and make determinations on what lands on the formulary. We, like Dr. Bachman said, we have a strategic approach to our purchasing program that attempts to avoid rebates and do direct pricing, direct cost, which is a much less kind of convoluted way to approach sourcing. So we have always we are continuing to review our utilization. Like he said, we look at our own data and we look at how we're doing with the medications we are using, and we tweak things and update the formulary based on that as well. We do have exceptions, as Dr. Bachman also mentioned. It's not, cookbook, and there are exceptions to every rule. And then we, of course, leverage very well our available generics and biosimilar products, which you'll see later on in the presentation. Go ahead to the next slide, please. So here's some more specific nuts and bolts of how we do utilization management. So the first box on the left represents a program we have called the Drug Utilization Action Team, which is tasked with saving drug costs every year. We attain $20 million in savings or more each year, and that is while upholding safety and efficacy first and foremost. So we leverage our purchasing power and ability to move our market share quickly from one drug to another. And you'll see an example of that later on. We also give a lot of provider feedback on how they are prescribing according to our preferred products. And we look for outliers and address those in partnership with our provider leadership. And we have a whole team of pharmacists who are academic detailers who actually provide that feedback and work with our, and it's a decentralized approach. So we have pharmacists who are assigned to different service areas who get down to the clinic level and work and build those relationships with those providers. So then the second box is around our generic substitution rate, and we are at 99%. So if there is a generic available, we use it, and we use it extensively. So we have a comprehensive drug list that is represented with 94% generics, and the US average is 89%, so we're above that. And members pay up to 50% less for generic medications than their brand name counterparts. So we are passing the savings on to our members. The third approach is just more generally, we make sure that, again, we also pay attention to efficacy and safety and even inactive ingredients when we're sourcing products, so that we make sure we have the best, highest quality products that we provide. And we also, once we verify that quality, we make sure we make every effort to get long-term contracts so that we maximize the savings, and we also maintain steady supply. So try to avoid those shortages that are very disruptive to everybody. And then the last box, Dr. Bachman mentioned earlier, but we do have a fully integrated EMR, electronic medical record, and it does provide a lot of decision support that pharmacy supplies through the formulary process. And we have what we call alternative alerts, and they are 75% effective for redirecting to our preferred product. So that is when a clinician goes in to order something, and it redirects them to what we prefer. And when that happens, 75% of the time, the clinician accepts an alternative and doesn't go with the original that they selected. So that's a really effective approach for us.
And that's a whole lot more both clinician friendly and member friendly approach than pre-authorizations and denials and stuff like that. So things are done in real time with the right medication, with the preferred medication at the right time.
We also have tools available to our clinicians that they can type in, like otitis media or ear infection, and they can get what we recommend for treatment for that condition. And so we have a list of about 100 different conditions, common conditions, that they can pull up in that way and get guidance on how to approach treatment. And then the last thing is that when we do have prior authorization criteria at the point of prescribing, the clinicians have that criteria at their fingertips to inform their decisions, so that they don't get hit at the back end when the pharmacy is calling them and saying this patient needs prior authorization and how do they meet the criteria or not. Clinicians have the opportunity to embed that into their documentation up front, and it's very smooth for the patient and for the clinician and for the pharmacy. So go ahead to the next page, please. So we also, because we're integrated, we have a lot of data, and we have clinical pharmacists who can provide additional support to our members, and we get those from various places. We have predictive modeling to kind of identify those outlier patients who may be using more resources and trying to kind of see what's going on with them and if there are opportunities to reduce that resource utilization and provide better care. We look at utilization reports, and we also get referrals from our physicians. And just a note about specialty care pharmacists. Dr. Bachman mentioned a few of the areas we have them embedded, and we really feel strongly that helps maximize the quality of care and also the use of cost-effective therapies. And one example is this year so far, we've been able to save $500,000 just in optimizing biologic therapy for dermatological, gastrointestinal, and rheumatologic conditions by having that pharmacist work hand in hand with those departments. Go ahead to the next page, please.
So this breaks down by our major drug categories, the cost drivers over the last couple of years. I would say dermatologic and anti-inflammatory, those are not really mutually exclusive at this point, which really, I mean, lots of the salves are in dermatologic, and those can be quite expensive, but nowhere near expensive as the cost of the anti-inflammatories that are particularly used for psoriasis or severe eczema, which are can be tens of thousands of dollars per month. So, and also some of those drugs that have typically been listed as dermatology can now be used for inflammatory bowel conditions, so they're not exactly the same. I really almost look at those together. You can see that dermatology drugs are going up. This is what we saw across the other plans as well. Cosentyx is our least expensive per month and is the one that's on the formulary when a biologic anti-psoriasis medication is needed, and it's the most used. Again, that's guiding our dermatologists being involved in the development of the formulary, and then also being able to adhere to our treatment preferences, which are based partly on cost and partly on effectiveness. You can see the anti-inflammatory class, which includes Humira and Enbrel, market reduction in 23 due to the adoption of biosimilar for Humira, which is Amjevita, and a very, very high % adoption of this within just a few months. So that's leading to reductions in that category of cost. You can see essentially stable HIV products, which are still quite expensive per member using them. That includes PrEP, which tends to be less expensive when Truvada is used. You have our diabetes costs going up since 2021. And that is due to increased use of the more expensive GLP medications and decrease of the cost of Lantus, which is a once daily injection used both in type 1 and type 2 diabetes. That's been helped mitigate some of those increased costs. We do have a slide that has more detail on that. Wanted to acknowledge cystic fibrosis, which is a significant cost driver in our PEB population due to the medication Trikafta, which is a medication that's been quite effective at reducing the morbidity of cystic fibrosis, changing the natural history at a cost of more than $200,000 per year per member using it. And finally, vaccinations, which is listed as medical pharmacy, but those are increasing as well as COVID vaccinations are now not being provided by the government, as there's increased indications for pneumonia vaccination, shingles vaccination, HPV vaccination, and we're kind of doing hepatitis B vaccines for everybody as recommended by the CDC. So that's just that's a substantial charge there. I also want to put that in the context of what we had talked about when we were talking about GLP coverage, which was going to come up at other meetings, but minimal GLP coverage is about $4 per member per month, and more liberal GLP coverages for obesity in other plans were estimated at up to $20 to $40 PMPM. So I just want to put that in the context. What addition of GLP costs would be if you were adding GLP medications for weight loss, how that compares to some of these other categories.
And Dr. Bachman, just a quick question: when you say that, is that driven by, the same drug having a brand name change, and for weight loss it costs a lot more than the same drug that has a different
number
name?
of people who we estimate would qualify for it, even with
Okay.
a fairly restricted criteria, making our recommendation a step care therapy if weight management pharmacotherapy is recommended. So even in a step care program where people try other medications first, our estimate for PEB would be up to about $4 per member per month. Anyway, I just want to put context on what these numbers mean. So next slide, please. Next slide gives a diabetes cost detail, and you can see there has been increases that are significant since 2021 for overall diabetes medication costs. You can see the price of insulin's going down, increased use of both SGLTs, which have some fairly profound cardiovascular benefits. Those are used both in diabetes and in heart failure, particularly when those are combined. Increased use of the expensive GLP medications for diabetes, and then increased costs of DME as well, which is primarily the expensive part there is the use of the continuous glucose monitors. So the overall PEB cost, 14% of our med cost is for GLPs in diabetes. That's a lot lower than the overall PEB cost that was reported as throughout PEB for GLPs. 32% of our costs are due to insulin.
Can you talk a little bit about why you think the utilization of the GLPs is so much lower in your population than what we're seeing in the other carriers?
Yeah, because we have been conservative about adoption for it, and they are used as an adjunct to insulin typically, as opposed to third line therapy for orals. So directly relates to our policy, which is available, which we've shared is available online. Sunshine, you want to add to that?
No, I think you covered it.
Yeah, and we're tracking our diabetes outcomes, which are generally favorable. Next slide, please. So this is just an example. The next couple slides is just how we more kind of detail with some data about how we achieve our utilization outcomes. One is through reducing variation in oncology care. As you look across the country, there is a lot of off-label use of oncology meds, a lot of less than rational use of very expensive oncology meds. We are able to, our physicians are in agreement about the oncology pathways, which are really based on highest quality data using NCCN, NCI pathways, and then adapted, but the system is designed to keep the prescription on track. Again, there are situations where we need to go off-label and make some assumptions, but that is done at a relatively lower level in Kaiser Permanente pharmacy, Kaiser Permanente oncology, and oncology pharmacy as compared to the communities. You can see that 78% of treatments are using the pathway, the recommended pathway for the specific drug, including the genetic findings on the pathology of the cancer. Next slide, please. And this is really the biosimilar story. Biosimilars cost 30 to 40% less than the specialty drugs that they are generic for. On the next slide, you can see what happened when Amjevita was rolled out on the next slide. And you can see that within 3 days for new prescriptions or a refill of the prescription, we were able to convert Humira to Amjevita, saving 30 to 40% of costs. That's just because we are organized, physician protocols, physicians were advised in advance, they signed off on the protocol. We trust that the biosimilar has been well vetted, which it has been. And then we also know that if this doesn't work out for an individual member, we're able to go backwards and get them back to the drug that was successful before. So this is data from Southern California, but it looked really basically the same in the Northwest region.
And I'd just like to add that this single conversion for us saved $1 million per day for the program for Kaiser Permanente nationally. So it was a gigantic savings and lift for us, and it has not changed the quality of care that we provide.
Okay, we have about 8 more minutes. I'm going to go quick to the next few slides. Flip 2 slides ahead to slide 17. And this is just, we were asked to comment on our specialty channel. And these are kind of things that were all mentioned with our colleagues at MODA and Providence, use of guidelines, limitations on the small initial quantities of expensive medications, and then use of a specialty pharmacy that's based in California when there's specific very expensive drugs, making sure that the drugs are being used appropriately. Next slide. And then by doing that, we're able to save a lot of money. I guess that's kind of, we can go to the next slide. And this was just responding to question there was just in diabetes, really the same thing. Same processes are being used, including high use of mail order pharmacy, use of our diabetes care management programs, utilization review when necessary when certain medications are done, having that all built into the ordering of medications. So. And finally, just a comment on mail order pharmacy, which is sort of ubiquitous in our system. 68% of PEBB, 63% in our book of business, and in PEBB it's even higher, 68% are using our mail order pharmacy. This is convenient, this is efficient, this is high consumer satisfaction, high level of helps with medication adherence. As you know, with the PEBB pharmacy benefit, members, when they use mail order pharmacy, get multiple refills for 3-month supply for 1 copay. Just comparing this to national, I couldn't find any kind of national data, but nationally, only 45% of individuals say they never used a mail order pharmacy, and only 13% consider a mail order pharmacy their primary pharmacy. I would say the majority of Kaiser Permanente members consider their mail order pharmacy their primary pharmacy for their routine medication needs. I have to remind patients when I'm prescribing something that's time sensitive, like an antibiotic or a heart medication, please get the first prescription at the pharmacy so you can get started on this medication right away, because people are so used to the great service at the mail order pharmacy. Okay, I'll turn it back to Sunshine on slide 22. Talk a little about medication, the member journey with complex drug needs.
Yeah, so this, I think, just speaks to our integration, where everything is available to the patient in-house, where we of course are an organization that believes strongly in the prevention side of things and screenings, and we do a great job of that. But as you go along in the journey, if you do have a diagnosis, we have multidisciplinary expertise, both pharmacy-wise and physician-wise. And we have a primary care physician that follows the patient throughout the journey. And then we add on cancer specialists who can see what the primary care physician has provided, and then vice versa, so that it's very integrated. And you can see the list there of all the different specialists we have available to our members. And then, the additional specialists, it's not to treat their primary disease, but to, support them in the journey as well. So you can see those below. And we're able to provide support every step of the way for our members who are diagnosed and treated with complex medication therapies, and even onto the survivorship side of things. So this is just an illustration of how integrated we are and what support we have available in-house. Okay, move to the next slide, please. So this is actually kind of revisiting what Dr. Bachman talked about with our national specialty pharmacy. So we have, it's similar to what you've heard from Providence and MODA about what specialty pharmacy does for our members. So I won't go over this whole slide. We do at the bottom, I did want to mention that we do have our local specialty pharmacists that I mentioned before, but part of their role is to connect patients who are experiencing financial toxicity or high drug costs with support, financial support for those cost share assistance programs, things like that, to help them be able to access those medications they need. So we can go to the next slide, please. So I thought I know this is primarily about cost and cost-effective use and how do we contain costs, and we all know that costs are increasing for medications, but I also, because we are a prevention-based system, and we truly believe that it starts with preventing severe disease to begin with, I just thought I'd mention some things about what we're doing around quality initiatives. And so this year we significantly improved our blood pressure control for all of our members, and also in our health equity focused populations. And you can see some additional detail on the right, but I won't go through that. We also improved our adherence to medications for diabetes, our statins for lipid, high cholesterol, and blood pressure medications. And we do focused outreach to members who may be late to fill these kind of life-saving medications and address any barriers that they may have. We are also really focused on reducing opioid use, and particularly in combination with other high-risk medications such as benzodiazepines, skeletal muscle relaxants, stimulants. And so we've really done a focused initiative to reduce those, enhancing our decision support, and also engaging our patients in wanting to get healthier, safer, and tapering down off of some of these high-risk medications. Also, just general opioid use reduction. We've reduced our overall opioid use by 12% this year. And we do a multi-pronged approach to that. We know that, there is a place for opioids, but, they are a dangerous class of medications. You all have seen in the news, and there are movies about it, and we really work hard to reduce the risk there. And then the last one is statin use in persons with diabetes. We know that's effective in reducing morbidity, mortality. And so we've really worked to increase the use of those in that population. And it's a hard road. Sometimes people are resistant to using statins. There's a lot of bad press out there in the past around that class of medications, but they really are evidence-based, particularly in patients with diabetes. And so we've been able to increase the use in that population by about 2% this year.
We provided in the appendix medication adherence data for PEBB, which for diabetes, high blood pressure, and high cholesterol are all quite high, 77 to 85%, and higher than our regional average. We're not doing anything specific for PEBB. We're doing these things across our entire commercial population, but I would just acknowledge that PEBB members are adherent to the medications and are engaged in their chronic condition management. So, which is good news for the health of PEBB members.
And I think that concludes our presentation. Thank you very much.
All right, well, thank you so much. Appreciate the last slide focusing in on quality outcomes, since we all do have to pay a lot of attention to cost, and that really is in an effort to make sure our members are getting the quality care they need. So I want to make sure we're opening it up to questions, because pharmacy is, a big cost driver, and people need their pharmaceuticals as well to get the care they need. So do folks have questions for Kaiser? Emily, go ahead.
Yes, thank you so much for that really helpful presentation, and congrats on all the successes. I had a question about, I appreciate the data, the regional data and the California data, but I wonder for, I think one of your initial slides, Pacific Northwest, are you able to break that down so that it's Oregon specific? So for example, I think you were talking about 26 pharmacy sites in the Pacific Northwest. I was just curious, what percentage, or which ones are in Oregon, or how many are in Oregon, or if there's a map, that shows where those pharmacy sites are.
Sure, we can provide that. So almost all of our ambulatory clinics have a pharmacy attached, as do our hospital, and that's where the 26 comes from. We have a few, that's both in our service area, which is Oregon down to Eugene, and then Southwest Washington up to Longview. So we think about our region, and there may be PEB members that live in Washington too. So when we think about a region, True. That's what we're thinking about. We're not including Kaiser Washington, and we're not including national in that. But when there's situations where some of the pharmacy programs and the benefit that we get from it is because it's not just our 630,000 members, it includes the 12 million members and hundreds of retail pharmacies and a dozen mail order pharmacies.
Thank you.
We can certainly provide a map where our pharmacy locations are.
Great, thanks.
Thank you both. And also just want to draw attention, as with the other carriers, we have a lot of good information in the appendix. Kaiser answered the questions that we asked all the carriers to answer, so we have a rich appendix attached to the presentation. So I want to pause again, see if there are questions. It's always a lot to digest. I know we're going to talk more about drugs this morning. We have a GLP-1 discussion on the agenda as well.
And that was just one of my questions. This is Greg. I know that you said that for you, and I want to make sure I understand. You said if we were to add the GLP-1 drugs, you were talking about a $4 per member per month. Is that actually for the drug itself, or for just? If you could explain that just a little bit.
That was that wasn't new information. That was previously presented either at the various conversations we've had about GLP drugs. That was our estimate of what the overall increased cost would be for adding an obesity pharmacotherapy benefit. That would be a conservative one related to GLPs, using GLPs after people have tried other classes of weight loss medications and are engaged in behavioral therapy. And I am not positive, but I assume that some primary care visits are included in that. And I don't think they're in the cost for the weight management program. I don't think is included in that because we don't charge members for it. There's no claims for it. So it really would be just for the office visits as well as the medication. When you get to the GLPs, it's the medication that's driving it because of the high costs.
Yeah, we've been looking at that a lot. I know that, I know that the amount that we've been given over the last couple of months, and beginning of the month, I had a pretty good discussion at CIAO that the costs are way higher than that. So I was just, that's what I was.
That was I don't think this was the preferred plan, but our recommendation was to think about obesity medicines, like think about other chronic conditions, using a step care model of care. So that was a lower estimate than other ones. It got into a $30 to $40 PMPM when you were not using step care and you're using GLPs first. So this isn't the time. I just wanted to put those dollars in the context of other classes of care for what we have for CF, for anti-inflammatories, for inflammatory conditions. That's really what I was trying to get to with that. That it wasn't, even at the most conservative, it's
$4 per month is pretty good for GLP. So that's what I was asking.
That's a pretty conservative.
That's what I was asking. So thank you.
But that's the same analogy that we're doing for GLPs for diabetes. We're being conservative about that as well, and using that as part of a step care process, which is why we're able to both manage diabetes at a relatively lower cost than competitors.
So I appreciate it. Thank you.
But it's also high touch. We also have a lot of staff, which doesn't get included in the PMPM, with their diabetes care managers, helping folks with diabetes and supporting them.
All right, thank you. So I've got Sarah Drake from Mercer, and then back to Emily. Sarah, go ahead.
Yeah, thank you. I think we talked a little bit about the difference we're seeing in the GLP-1s with your population compared to the other carriers and your different approach towards treating diabetes and really having those GLP-1 drugs later in the course of therapy. Do you have any evidence yet on what does that mean for outcomes for the people that have diabetes? Do you have any evidence to show what the differences are in A1C levels or other metrics that measure diabetes? And the reason I ask is we've seen just more information coming out from the American Diabetes Association, some of the other groups that have the GLP-1s earlier in the clinical guidelines. So I'm curious what you're seeing with your different approach.
I don't think I can answer that specifically. I don't think we've looked at the data that way. I'm not aware of it, but it is something that's we do follow the diabetes outcomes for population related to the HEDIS metrics, which do include diabetes control. We do follow rates of cardiovascular disease prevention. I would say for our cardiovascular disease prevention, statins are critical, and SGLTs are critical. And then it's sort of left to our regional formulary committee in terms of what the appropriate guideline is, which has been somewhat changed over time. And it's obviously under high level of scrutiny with frequent follow-ups on this issue in particular. But currently we're comfortable. We feel like our guideline is consistent with the evidence, is consistent with outcomes, and is what we think is the right utilization guideline. So we can certainly, if you want to have our diabetes experts report back or have a conversation with you, we're certainly happy to do that. But I've been in close communication with the folks on the RFTC, and Sunshine's on that committee in terms of our guideline, and we feel like our guideline optimizes both outcomes and as well as cost efficiency.
I think as more data is available, we'd be interested in seeing any outcomes data that you have.
Right.
I will say that we are constantly, updating based on evidence that comes out, and there is new evidence that we are considering. So it could very well change in the new year, our approach.
Thank you. All right, Emily, go ahead.
Yeah, I just really appreciate all the specific examples that were shared throughout the presentation. And Sunshine, you had mentioned, I think, ear infections maybe for one example, and it just made me curious and maybe this is outside of the scope of this conversation, but for ear infection treatment, and I'm thinking about the value for alternative health and healing approaches for certain communities, tribal communities of color, immigrant communities, would the way Kaiser or other carriers do it, if they diagnose that there's an ear infection, are the treatment options only medications, or is there room for any like chiropractic adjustment, for example, with ear infections for young children, which I know some naturopaths and chiropractors recommend?
I don't know the effectiveness of that treatment. I would say we sort of shortcut it a little bit. I mean, when a decision to use an antibacterial antibiotic is made, then the electronic medical record helps guide us to the most appropriate evidence-based treatments and duration. That's just a very simple example, but certainly with ear infections, there is a role for observation without antibiotic therapy, as there is for things like diverticulitis. And there's a series of things that you can watch and keep a close eye on and don't need to jump to antibiotics. So, and I don't know, and then clinicians are aware of the alternate care available, though to be honest, I'm not sure how many would recommend chiropractic for ear infections versus watchful waiting.
Okay, thank you.
But that's a fair question. I mean, that's so.
Yeah, I know a lot of Native children have chronic ear infections, and I believe there's research that shows the angle of the tubes is a little different and just needs to be adjusted downward, like a downward slope, so that the liquid can drain better. And so I think that's one of, yeah, thank you.
All right, well, thank you for the questions. Anything else? Dawn, go ahead.
If I may, Emily, thank you for bringing equity to the fore in that very specific question about culturally responsive healthcare alternatives. I would welcome, sort of in an ongoing way, I would welcome specific culturally responsive options among the carriers covered services in conjunction with appropriate evidence evaluation as one of the ways that we can sort of help our very white-centric system evolve to acknowledge the incredible diversity of our communities and members, and acknowledge the ways that our evidence base sometimes doesn't do as good a job as it could or perhaps should of describing different kinds of therapies if it's not coming from, for example, a well-funded pharmaceutical company that has a lot of resources to do research that meets our criteria. This is a really hard problem, a complicated one. We don't want to be supporting treatments that do harm, and the ways that we understand benefit are not necessarily as responsive as they could be. So I welcome the participation of the deep professionalism and training and thoughtfulness of our partners, Kaiser being one of those, in helping us evolve our system toward one that is more culturally responsive and still driven by the best available evidence.
Appreciate those comments, Dawn, and Emily, thanks for your questions. Any last questions or comments? We're going to move to break in a moment before we go into our doula discussion. All right. Thank you, everyone. We will come back at 10:40. Right, welcome back, everyone. So coming off of break, we are going to have a discussion around doula coverage. And Christy Ewing, I believe you're here from Mercer. Hello. I'll hand it over to you.
Hello, thank you. Hi, everybody. So I'm going to cover doula today. So if we can move to the next slide. And so first what I'm going to do today is just share a little bit of background, kind of about how we got here to have this conversation today. And so CEOW, which is the Strategies on Evidence and Outcomes Work Group, had a research group that started this summer of 2023. And the group was really, reviewing emerging information on doula coverage. And this is a joint project for OEB and PEBB. Really within this group, what we did is we looked at the research around doula services, the impact that it's making on clinical coverages, as well as reducing inequities. And additionally, we looked at, kind of what coverage would look like, what are other states doing, what is the commercial market doing. We looked at coverage options. And then ultimately made, kind of settled on a few recommendations, which I'll share later. One thing to note is I believe the January CEOW meeting is where the CEOW group will be making their recommendation. And then also just wanted to share that doula coverage right now is not offered, doula services are not offered under the PEBB plan. However, it is offered in Oregon under the Oregon Health Plan for Medicaid populations. As part of our conversation around doulas, we really needed to first define what is a doula, because there are different types of doulas. And so in the context of what I'm talking about today and really what our group ended up landing on was the term of birth doulas, which really is offering prenatal, birth and labor support, as well as postpartum support. Also, just wanted to share that birth doulas are, they're non-clinical, trained professionals, and they really do provide this physical, emotional, and really educational support to the birthing person. And this support in best practices is going to start as soon as the birthing person knows that they're pregnant, to build a relationship, then to also be there for the birth and labor, and then again to offer postpartum support up to 1 year after the birth. And then specifically here in Oregon, there is a doula certification. It includes an OHA approved curriculum, and then that doula needs to enroll in the state registry for traditional health workers. If we move to the next slide, as I kind of talk about clinical findings, first I just wanted to, say that as you may know, that, the number of maternal deaths nationally has been increasing, and many of these deaths are preventable. I guess additionally, I just want to say that, pregnancy-related deaths also disproportionately impact Black, American Indian, and Alaska Native birthing persons, as well as birthing persons that are living in rural communities. And so doula care, doula services have been found to make quite the impact on maternal deaths and overall for the birthing experience. So here's just sharing some of those clinical findings. A lot of the research and literature right now is within the Medicaid population. And so that's where a lot of this data comes from. But you can see here a 40% reduction in C-sections, lower use of pain medication, lower odds of preterm birth. There's a big decrease in the rates of postpartum depression, higher APGAR scores for the baby, increased breastfeeding rates, and then also shorter labors and, overall a better experience for the birthing person. As we move to the next slide then, as we started to dive into this a little more, I just wanted to share today kind of what does the landscape of doula services look like. And so as I said, In several states, as of August, there was 11 states that are offering doula coverage for Medicaid populations. There's actually 8 more states right now that are reviewing doula coverage, and hopefully we'll be putting that into place. Benefit design really varies across the different states. And so we really looked at this so that we could, obviously come up with what a best recommendation would be for what this coverage would look like. Benefit designs range from 2 visits plus the birth and labor up to 12 visits across different states. And you can kind of see what that is here. In Oregon, there's 4 visits, so 2 prenatal, 2 postpartum, plus the birth and labor is what is covered right now in Oregon. One thing I'll just say too about Oregon is we did meet with an analyst with the Oregon Health Plan who did share some of their early findings of these coverages, and overall shared that really the 4 visits is not enough and is not meeting the needs of the members that are using the doula services. In the commercial doula coverage space, Providence Swedish Hospitals in Seattle has a doula program. The cost ranges from an apprentice, which is about $800, up to a higher, more experienced doula, can go from $1,200 to $3,000. I have a little snippet here of kind of what that service and coverage looks like. In Mercer's recent health and benefits survey, we had about 23% of our larger employers do have some type of coverage in place for doulas, midwives, birthing centers, or some alternative to improve the birthing outcome. And then one state, Rhode Island, actually does require doula coverage in fully insured private insurance plans in addition to their Medicaid plans. Moving on to the next slide. Also, as part of looking at doula coverage and services, the Health Equity Work Group worked in partnership with the CEOW Group and just kind of bringing to light some of the health equity considerations. So while doula services obviously are filling and hopefully solving for inequities, there also can be inherently in the benefit coverage, we wanted to make sure that it was equitable for what we were looking at and looking at all of those considerations. So I'm not going to read through every single one of these bullet points, but a couple I'll just kind of highlight. So within the doula network, making sure there's access. So having coverage for the services is one thing, but then also making sure that there's access. That was another finding in speaking with Oregon Health Plan, was that currently, from the information they had when we met, which I think was about August, is that they felt that doula services was still an underutilized benefit. So it was really hard for them to really be able to have an opinion on whether the network was sufficient or not. As of July, there were 221 doula certifications. And the estimate was about now that they're probably closer to 300. Oregon has had an increase in the reimbursement rate for doulas in the past year. And so that has brought some more doulas into the workforce and completing the training and the certification. A couple things in the network that's also very important is to partner with community-based organizations to ensure diversity of the doula network. And then another possible thing to consider is helping with funding or supporting doulas coming into the network as well. In plan design, really the most important here is just really making sure there's adequate visits for the full spectrum of doula care. Again, recognizing that prenatal, birth and labor, as well as postpartum is really important. In the reimbursement, just again, looking and making sure that the reimbursement rate for doulas is equitable and fair and competitive, and that, really taking into consideration the full amount of time that doulas spend with the birthing person. A lot of the literature showed that doulas spend way much more time, up to 32 hours, beyond what the reimbursement is for. In the reporting realm, just really making sure that we're collecting race and ethnicity language data, that there's some type of standardized reporting to capture that information from doulas, and then also having that integrated into the electronic medical record so that the full team can know that that person has a doula for support and recognizing that that's part of their care team. And then lastly, in communications, I would say one of the big things here is to really have communication amongst the clinical team, introducing the doula and providing the benefits of the doula and what their role is, so that there's clear information about what the scope of the clinical team is, what the scope is of the doula, and how they can work collaboratively and partner together to support the birthing person for the best outcomes. Next slide, please. All right, so then we kind of dove into the financial considerations. And so you can see here on this slide, a couple assumptions we made as we were doing these financial considerations is that we did use the reimbursement rates that are currently in place in Oregon, which is $215 per visit plus $640 for the labor delivery time. A couple other assumptions, because on here we are showing a net cost. And so what we did is we assumed a 15% utilization of doula services. We also then applied a 30% reduction in current C-sections for PEBB, and then also a 22% reduction in preterm birth. Those were kind of the two metrics that we could get good data and kind of also say what the impact is. All of those other benefits I shared of doula services are just much harder to quantify. So they are not included in our financial estimates. And so as you can see here, I'm going to skip. So option 1 would be obviously no coverage for doula services. Option 2 is the 4 visits. Again, we did that because that's currently what's being offered through the Oregon Health Plan. But as I shared earlier, we learned that that really is not meeting the needs of most birthing people. And so then option 3, our recommendation is the 8 visits plus birth delivery. That showed about a cost impact of about 0.03%. Again, I just want to share this is Mercer's recommendation here as option 3, and the CIAO group will be meeting in January, I believe, to formalize their recommendation. A couple things about how we came up to our recommendation. Obviously, doula services are shown to really improve health equity and maternity outcomes. It is in line with what we found for benchmarking in the Medicaid space across different states. And then again, some of our learnings from the Oregon Health Plan really helped inform this recommendation as well. Any questions, comments? That was fast and furious.
Glenn, you have a question? And then Emily.
Yeah, mine's more of a clarification. Actually, the CIAO recommendation for the doula and the weight loss drugs won't come till February. The CIAO meeting was canceled in January. I believe, Christy, you had left by that time at our leadership meeting. So it won't come till their February meeting.
Thanks for the clarification. Emily, go ahead.
Oh, thank you for this presentation, for your team's research. I'm excited about this. I also work in the Equity and Inclusion Division at OHA, the home of the Traditional Health Worker Program, including the birth doula program that you're talking about. But then also I benefited personally from a doula in the birth of my child. I married into a Native family, a Nez Perce Umatilla family. And so that actually made me eligible for a Healthy Start program that, like you were saying, Christy, sort of targeted Black, African American, and Native birthing people, and because of the higher risk for infant mortality. And so I credit that program for so many positive outcomes. For my birth, it was my first birth, and I hadn't realized that I had some, I had inherited some trauma from my mother who was Taiwanese. But when she gave birth to me in Illinois in 1971, she couldn't speak English. She couldn't communicate with the doctors or any of the nurses. They wouldn't let my father, who could speak English, they wouldn't let him into the room with her. So she had a lot of traumatic childbirth experiences with myself and then my two siblings after me. And so this doula actually came to my home before I gave birth and did visits with me, did word association games with me. And that's where she discovered that I had sort of, and I didn't even realize it, but sort of these negative kind of feelings about childbirth and fear. And she was actually able to help me work through that. And it was a partnership, actually. It was a partnership with the public health nurse who was at the American Indian Family Center. And then it was the doula that was also with the American Indian Family Center. And then it was my OBGYN at my health plan. So it was a partnership between the three. And so, I'm just curious as to, I really believe in that home visiting model and, public health nurses doing home visits. I'm pretty sure we have that kind of thing happening in Oregon within our public health division. So just planting the seed in terms of, exploring potential partnerships to get past this just 4-visit limit and to go beyond that. I mean, the OBGYN, everybody was just amazed that it was my first birth experience because I had such positive outcomes after the doulas, the doula and the public health nurse at the American Indian Family Center's support.
Thanks, Emily. Oh, Dawn, go ahead.
No, please, if you wanted to react directly to Emily.
I was just going to share in our CL group, we also have heard from some doulas and their experiences of delivering care. And it was one story, and I know it was really meaningful for a lot of us, was just a birthing person started speaking in her native language during the birth and labor. And she just felt she was not speaking English, so she had no way of communicating. And that doula was there to really be that conduit and be able to understand her native language, and then also, then be able to share with the clinical team as well. So just some amazing stories. And Emily, I thank you for sharing yours.
Go ahead, Dawn.
Thank you. Thank you for that story, Emily, and for your willingness to share it with this group. I think it's a very poignant story, and I'd like to point out a couple of things about it. One is that it is now all of the carriers' obligation to provide interpreters, and I hope that's happening to help mitigate that experience for current generations of birthing people. And it shouldn't fall to doulas to do that. That's not their primary role, but they do serve not only as interpreters for language, but as cultural interpreters often, because the language is only the beginning of the communication and care challenges that discordant providers and patients face in trying to ensure the delivery of culturally responsive care. As a white woman doctor, I have taken care of lots of people who I was working pretty hard to understand, and I know I wasn't doing as good a job as I wish I could have done. So gratitude for that, gratitude for doulas too, and there's a whole lot that's not listed here. Thank you for your work and for your presentation. There's a whole lot that's not listed here in the way of economic return on investment, as well as healthier outcomes, fewer C-sections, better breastfeeding, a lot of other maternal-child health outcomes associated with doula care, which supported our increase of the doula reimbursement through OHP, which was a project that I worked very closely with our analysts on. And it's one of the things that I'm very proud of because of doula's ability to deliver equity in a way that our traditional systems struggle. So I would support this proposal, not at the 4 visits plus birth and delivery, but at an increased amount if in fact this emerging experience from the OHP plan is indicating that 4 visits don't meet the need. I've reached out to the analyst and I intend to learn more about that to see what we need to do to better meet people's need with that service. But the number of people who have access to and then actually access doulas, I think needs to be increased. They're a wonderful example of one of the ways that we can decentralize our investment in healthcare delivery to result in better health and outcomes outside of the exam room. So thank you for this proposal.
Yeah, I just want to echo thanks on that. And I know we'll be looking at these options in the spring when we're doing renewals for 2025. And thank you to Andy and Greg as well, who serve on the CIAO committee. I know, Christy, you also have taken this to the Health Equity Committee that PEBB has, and we've discussed it too. So certainly been having lots of discussion around the benefits of doula care. So any last questions or comments? Greg, you came off mute. Go ahead.
Yeah, I just wanted to say that, you know, in looking at where it was, the beginning of the month, we did have quite an extensive rundown on this with the CIAO. And I believe they, as well as us, when we looked through this, the end, as we said, was that, you know, no coverage, of course, is not an option. 4 visits is not enough. 8 visits, you know, to start may not be enough. But I think it's something that sitting on this committee and going through, which I had really never heard of one till I started this. And after going through some of the data, seeing that the percentages that this saves in from not only from, you know, the family perspective, but what this saves in costs for us down the road in different medical procedures or C-sections or those types of things was actually, it was very overwhelming, the amount of what this saves. And I think what was brought up in CIAO that is something that we don't often think of is that everybody in the room is there for the baby. And it was something I hadn't thought about that was brought up in that meeting that someone had brought up, is that, you know, the doctor's there for the baby, the nurse is there for the baby. Of course, they're there to help the mother, but they're there basically for the baby, the well-being of the baby, the delivery of the baby. And the doula themselves is actually there to help the mother through that process. And by working with them prior, they have more of a relationship. And sometimes if you have a doula who, you know, in our, you know, the equity part is huge. If we have a doula that actually speaks 2 languages and they can relate to that mother different things that maybe a doctor cannot in the time of birth, that as well helps calm that mother or help her have a better situation or you know, a better birth, which in the long run helps her you know, out the door. And you know, I mean, there's 2 sides to this. There's the medical and the dollar side, which of course we are in, but at the same time we also have that side that helps our not only maybe our next door neighbor who works with us, you know, but you know, those coworkers that we don't know. So that's my 2 cents. I think it's a great deal.
Thanks, Greg. So we can expect this presentation to be referenced in the spring when we talk about changes to 2025 health plans. So thank you, Christy. And now we're going to go into a GLP-1 discussion. We've got several people to help lead on that, from Mercer, Sarah Drake, Andrew Hoffheimer, Dr. Mary Kay O'Neill, and Emery Chen. Hand it over to the 4 of you.
Thanks, Siobhan. This is Andrew. I can kick it off. Good morning, everyone. Glad to be with you here today, leading what is what I'm sure will be a very robust discussion, because this is a very nuanced topic that that we've been working on for some time now. Before we sort of launch into the content, I'll just make a couple of comments on our journey and how we got here. It was about a year ago that public comment was first submitted by PEBB membership, asking the PEBB board to evaluate removing the weight loss drug exclusion. And so around this time last year, when we were kicking off the 2024 renewals, we had a lot of discussion on this topic. It was at that time an emerging issue. It still largely is an emerging and changing issue. But nonetheless, we tackled it, and ultimately the board decided to defer on the decision and more deeply study some of the issues. And to do that, a work group was formed, which really was tasked with researching some of these topics that we just needed to shine a light on a little bit more. So things like coverage policies and FDA label requirements and rebates and lifestyle support and utilization and a bunch of other topics. And so the purpose today really is to get the PEBB board up to speed on the findings of that research group. And really just, have as robust of a discussion as possible. We've tried to keep our slides sort of short to allow for plenty of opportunity for discussion. We're not asking the board to make a decision today. Similar to doulas, that will get folded into the renewal process, which will start in early 2024. But with that said, again, just please chime in as comments come to you, and we will do our best to facilitate this discussion. And so I've got a number of colleagues with me. Sarah Drake from our pharmacy team, Dr. Mary Kay O'Neill from our clinical team, and Emery Chen, our lead consultant, and so, our lead actuary. And so between the four of us, we will walk through these slides. And to kick us off, I will hand it over to Sarah Drake.
Thanks, Andrew. As we all know, obesity, cardiometabolic disease, it's a challenging, it's a chronic disease, and it's a complex and a challenging topic. And we've spent a lot of time over the last several months really digging in and trying to better understand all of the moving parts around obesity, around GLP-1 treatment. Many people in the US, including many PEBB members, have spent months, years, many cases decades, trying to treat this challenging disease with various regimens of diet, exercise, and often even prescription drugs or supplements that are marketed for weight loss. And yet they still haven't achieved their health goals. And so these drugs do represent a new tool in the toolbox that people haven't yet had the opportunity to try due to a combination of availability on the market and then also cost factors. And yet people are very understandably eager to try them. And if you read through some of those public comments that were submitted, you can feel that sense of urgency in their comments. At the same time, I think as we go through this, any discussion of coverage needs to acknowledge that the successful treatment of the disease that is cardiometabolic disease and obesity generally can't be accomplished through drugs alone. We need to recognize that there are environmental, social, lifestyle factors that have contributed to the rise of disease in our society and our workplaces. And we need to think about how can we move upstream to help people ensure that they're going to be successful in maintaining a healthy cardiometabolic state over time, and also prevent more individuals from developing obesity and cardiometabolic disease moving forward. So with that, let's get started on the next slide. And this is just a brief overview of what a GLP-1 drug is. So what is a GLP-1 drug? It's a mouthful. It's glucagon-like peptide 1. And that's a hormone that's produced in the intestine in response to the presence of food. That GLP-1 hormone increases the production and release of insulin, and it also increases the feeling of fullness during and between meals. These classes of GLP-1 agonist drugs are not new. There's been various products available for the treatment of type 2 diabetes for over 15 years now. Some of the early products had to be given daily. The newer products allow for just a once-a-week injection. We've even seen some oral products approved for diabetes. Even more recently, we've seen some of the newer GLP-1 drugs used for weight loss The FDA actually approved Wegovy to be used in weight loss in conjunction with diet and exercise in 2021. And Zepbound was approved just last month by the FDA. As of today, PEBB, as well as OEB, Medicare, and Oregon Medicaid exclude coverage of all weight loss drug treatments. And that would, of course, include the GLP-1s used for weight loss. There's a lot of complex considerations associated with the decision of whether to add or defer coverage of these drugs for weight loss. They have the potential to be part of a regimen that can help move people towards health. But there's also some safety considerations, as well as, like I described earlier, social, environmental, and lifestyle and cost factors that do need to be explored as well. We go to the next slide. As Andrew mentioned earlier, there was a summer research group formed to study some of the complex considerations around GLP-1 drugs and GLP-1 coverage. By convening that summer work group, we had the opportunity to study the potential opportunity and the potential impact of these drugs. And we were able to include participation from both OEB and PEBB. The group met several times over the summer, also included participation from the carriers, Mercer, and both boards, as mentioned earlier. On this slide, you can see a little bit more detail on who participated in the group and then what was considered through that process. Broadly, the group looked at putting together coverage policy options and also considered how GLP-1 drugs would fit into an overall treatment spectrum for cardiometabolic disease. We explored a wide range of clinical considerations, and you can see a lot of them listed here. The group did focus on coverage and treatment for adults and did not delve into coverage for children or adolescents at this time. The group also did not weigh in on what or if there was a specific lifestyle modification program that would be optimal to pair along with a GLP-1 drug coverage. And then just for some quick clarification, as we heard from the Kaiser presentation earlier, GLP-1 drugs are currently covered in both PEBB and OEB when used for the treatment of diabetes. So the focus of the research group was just solely to look at the use of the drugs for the treatment of obesity. Let's go to the next slide. We probably don't need a lot of explanation here, but I have to say, I've been a pharmacist for 25 years now, and in all of that time, I have never seen this level of consumer interest and excitement and conversation about any drug class. And that includes the time period when we looked at hepatitis C in the 20-teens and even the advent of Viagra in the 1990s. I've never seen anything like this in terms of interest. It's an interesting poll there. The Kaiser Family Foundation, which I need to disclose is not affiliated with the Kaiser Health Plan, but the Kaiser Family Foundation conducted a survey in July of this year looking at the public's views on the new weight loss drugs. And they had a representative sample of about 1,400 US adults, and they found that 68% of people who wanted to lose 20 or more pounds would be interested in taking a drug for weight loss if it had been proven safe and effective. 50% of people were interested if they were just trying to lose up to 20 pounds. And 23% of people who were not even trying to lose weight would be interested. And so I think this just speaks to the level of interest in drug treatment for weight loss for obesity. PEBB has received a number of requests for coverage. You can also read some of a sampling of some stories in the public comments. And in addition, you'll see public comments submitted from multiple groups, including the Obesity Action Coalition, the Pharmacy Industry Labor Management Association, the National Consumers League, the Alliance for Patient Access, and the American Diabetes Association, all advocating for coverage of or removal of the exclusion for weight loss drugs. You know, what's driving this demand? I think there's a number of factors. There's a high and growing prevalence of obesity and cardiometabolic disease in the US. There's a lot of people who are seeking to lose weight feel like that standard advice of eat less, exercise more just isn't working for them for whatever reason. And then we also certainly cannot discount the impact of social media and advertising. There was nearly 500 million spent halfway through 2023 on ad spending on Wegovy alone, And then the ad spending on Wegovy alone was up 1,000%. And this is even before the Oprah factor, which was announced last week, where Oprah also said she was using a drug treatment for her weight loss. We can't discount the drug manufacturers. They're master marketers. They know what they're doing. They do it quite well. But the demand isn't just coming from the consumers, and it's not just coming from pharma. If we go to the next slide, we can see a quote here. Medical providers are advocating for coverage too. And you've seen the Oregon Medical Association in their public comments are supporting coverage for GLP-1 drugs, and they request removal of that exclusion language to give plans an option to cover. And you also received some public comments from a group of Oregon clinicians that are managing patients with obesity. We also saw in the last year, the AMA passed a resolution calling for health insurance coverage parity for clinically validated obesity treatments, and that would include products like Wegovy and Zepbound that are FDA approved. I can stop here to see if there's any questions before we go on. Otherwise, I'm going to turn it over to Dr. Mary Kay O'Neill to talk about some of the considerations around weight loss interventions.
Thanks, Sarah. And again, please, anybody with comments or questions, just join in here. This has been quite an interesting time, as Sarah has been outlining. I think we've discussed within our own group how unusual it is that some new treatment option of any kind sort of entered the consumer market with this much attention and this much interest. And I also I'd like to point out one of the things that that was pointed out by Sarah in the history of coverage for PEBB and OEB, and this is not unusual for these organizations. Many companies and many systems did this. They just sort of categorically excluded treatment for obesity historically. That was just not on the radar screen. So this is giving us a very interesting dynamic right now of a drug that has a lot of great support from the clinical research literature as being an effective drug for this condition, which, as we all know, is a very common condition in our population in general. But it's sort of landing as Sarah really, Sarah said all the most important things. I'll just put that out there right now. But, it has landed sort of on everybody's consciousness without kind of a really good infrastructure to support people who are likely to use it and need support around other aspects of their life and health as they start using this drug and make sure it may be the most, useful tool to them, which includes, behavioral health issues. It includes dietary issues. It includes activity issues. It includes management of side effects. And as more and more people use it, the side effect profile is becoming clearer and clearer. There are some things that are tricky about this. There are some things that are tricky about using this and maintaining really good health from a nutritional standpoint, because with the lack of appetite, people don't always still choose the best foods to eat, right? So there's some issues around that. And then there's the issue of, cost. And we've had Emory's taken a close look at this, as have many other people at Mercer, like what is the impact given how many people would qualify for this medication. And I think there are a couple of things in the comments that were well taken. That some of the scary financial figures have to do with, sticker price of meds, not including the rebates, and also this assumption that a very high number of people may take this. And there are personal reasons why people don't even start on this. But nonetheless, if this is to become a benefit, you certainly want it to be valuable for the people using it and valuable to you guys as, providing health for the population that you serve. So that's going to take some attention to the individuals that enter into this care. So I think, that overwhelmingly in the commentary, people that are involved in the clinical care of people with this condition are in support of this. I recently was on a panel in Washington State that was run by the Governor's Collaborative on Healthcare Improvement, the BRE Collaborative, that included clinicians at University of Washington and in private practice around care for people with obesity. And I think they were generally, I mean, they wanted to be able to prescribe this drug. They described it as a safe drug, but they just also acknowledge, I think, those points that Sarah made, that people needed support as they go through this journey, right? That it's not just a med that would, that you check the box, give them the med and everything's fine. So can we move to the next slide? I'm not controlling this. So I think that everybody on this group is probably well aware of all of these different impacts of these different kinds of programs. And I think some of the traditional diet and exercise programs and things like that got sort of pushed aside because people felt they weren't effective enough. But certainly that's a definite part of health and health status, and I think needs to be part of any kind of program that includes these medications, looking at, what people have to deal with and making sure that the impact is what you want it to be. And I think, we've had some experience. I was sort of early on in the far end of this slide on bariatric surgery, and that, of course, is become very, it is not a perfect solution. People can gain their weight back. There are longer term health consequences, but many people have gone through this procedure and had good results, but I don't think it's for everybody. And then I think the issues that Sarah brought up about this drug classification having been on the market for 15 years, it's not like an unknown drug, even though the use was limited for the most part of that time frame with people with diabetes. But as you guys all know, that obesity is a significant comorbidity or type 2 diabetes anyway. So I don't know if you have any questions about this, but concerns?
I mean, my only question is all the references to 0 to 5%, 5 to 7, those aren't increases over what we're paying now though, right? Those are just costs.
Yeah.
Or could you explain that?
Those are weight loss average in a year.
Right, but that's not like, oh, we would be paying that much more. That's just the average of what we're paying now, or what's being paid overall for these interventions.
Yeah, that's the sort of the average price for those types of interventions. So for a traditional diet and exercise program, the estimated cost of 1 year of treatment of that kind is $500, and the impact is 0 to 5% weight loss.
Got it, thanks.
Yeah, I know, lots of numbers in a row there. So
Andy, go ahead.
So my question is, when we look at the numbers for the 1 year, and this might be something you're going into later, like I know with Mercer's recommendation, it was looking at people taking this drug for 6 months. But is this actually going to be something people can go off of? I mean, is that because it just doesn't seem like that's going to happen? So I'm just curious. I mean, I guess I'm just looking at the bariatric surgery. It's $20,000, but that's a one-time deal. Not that I recommend that, but are we looking at, $16,000 each year? So anyway, that's and if you're going to answer that later, that's fine. I'm just that's what I'm curious about.
Well, the clinical answer to that right now, and these come from recommendations in large part, I think, from the people that are manufacturing this drug class, but also from people I've spoken with that are treating this group of patients, is that the idea of these medications is that they will be a chronic medication. So how it's actually used and how people choose to stay on it or not, has to do in some degree with the side effect profile. And so not everybody that starts stays on it forever. What we don't have from a clinical point of view is the experience of having people be in a more programmatic approach to this care, start on this medicine, and then say they're one of the ones where the GI side effects are not something they want to live with forever. Can they be transitioned to a non-drug based treatment and still have success? There's a lot of argument about that, but what I will tell you is we don't have a track record of data on it. And so Emory knows more about the costs and the discounts and the averages and things like that, but those are the clinical pieces of information I have at this time.
Perfect, thank you.
Yeah. And you can see on the statistics at the very bottom that this is an evolving area. And I guess saying that only 35% of employers cover this for obesity management outside of treating diabetes tells you that we're at the beginning of this, right? That we still have quite a bit to learn about how this works and for individuals and across a population. Do you want to go to the next slide? So, I think there's lots of public data on rates of obesity that really cut across all kinds of groups within our society. It has historically been a little bit of a hard piece of information to get out of claims data and things like that, but we have a lot of other sources. And we know that, of course, that there are some differential impacts in different groups within our society. And like Sarah was pointing out, people who are living in environments where they have economic distress, food deserts, all of those kinds of things, where there are a lot of reasons for people to have this particular problem. That it impacts people more heavily. And we also know, even with the history of probably not the best organized approach clinically to this problem, that people in different groups get different levels of treatment. So from an equity perspective, looking at who's getting help, what their issues are, what their medical comorbidities related to obesity are, and how to help them most effectively. I think that's another very emerging kind of information that we have. I mean, we know who's differentially impacted by obesity, but we don't have all the information about how to set these programs up and put these resources in front of people in the most effective way necessarily yet. That's still part of our learning curve, I would say.
On this particular slide, Kaiser, is that PEBB or is that Kaiser overall?
I think this is an overall Kaiser number, but I did not put the slide together, so I am guessing, but it says of its membership, so I would think this is their larger data.
So just noting it's much higher than for Oregon overall.
Yeah.
So just a couple things to comment. So first, our data is collected at the time of care using individuals coming into clinic, which isn't everybody. There's a third or 25% who don't come in the course of a year, probably because they're healthy. So that can skew the Kaiser data. The PEBB data is a little bit heavier than the book of business. I can't remember which one was used here. We'll track that back and let you know, put that in the chat. The way Kaiser collects this data is pretty similar to NHANES, having people come in with light clothing. So that's the issue in PEBB is real. PEBB members are certainly heavier. Now, the other thing I would say, it's the 12% with a BMI above 40 that we see in our population. That's also a significant consideration.
Thanks.
Thank you. So I don't suppose this data surprises anybody, right? So we can go on to the next slide.
And I can take this one.
Yeah,
so
that's good.
So I think you've probably heard me or Dr. O'Neill or someone talk about the FDA approved label or the labeled indication. And the purpose of this slide is just to make sure that everybody's on the same page about what we mean when we talk about FDA labeling. So when the FDA approves a drug for use, they approve not only the drug, but actually the labeling too, which includes the packaging, the carton, the container, and then also the prescribing information. And that prescribing information is known as the labeling for healthcare professionals. And then there's also separate labeling for patients or caregivers, and you might see that referred to as a med guide. But anyway, all of this needs to be proposed by the manufacturer, and then it's approved by the FDA before any drug can be marketed in the US. And so what you see on the right here is an actual excerpt from the Wegovy label. And this is the indications and usage, and then also the dosage and administration section. The label also includes a lot of additional information that you don't see here, including warning, side effects, clinical trial data. But in that indication and use section, it tells you what populations and for what use the drug was proven effective and the FDA has approved its use for. So in other words, FDA label indicates the population and the conditions under which the drug was actually proven to be safe and effective in the clinical studies that were submitted to the FDA by the manufacturer. So in this case with Wegovy, it's been proven effective in those populations for weight management as an adjunct to to lifestyle changes like reduced caloric intake and increased activity. And the manufacturer of the drug might point to the labeled indication as part of their price negotiation strategy. And we see this a lot. So for example, we've seen cases where there's an employer that might like to cover the drug, but only for the highest risk individuals. So maybe BMI of 40 or higher. And the drug manufacturer then will often say, well, unless you cover this product for everyone for whom the drug is indicated on the label, we're not going to offer any discounts in the form of rebates. And so the label is both, it's an informative tool on when and for whom the drug is actually proven to work. And then it's also used in marketing and pricing considerations. So that's why I wanted to show that here. Also, I do want to note that once a drug is approved by the FDA for a specific use or specific population, there's no requirement for prescribers to prescribe it only in accordance with the label, right? We've all heard about something called off-label prescribing, and that's when a prescriber writes a prescription for a patient who doesn't meet the criteria on the FDA label. So, for example, on this label here, if a doctor was to prescribe it for someone who had a BMI of 25, that would be off-label prescribing, and and it hasn't really been proven to work for that population. Another good example is Ozempic's FDA label indicates it's approved for improving glycemic control for people who have type 2 diabetes, and then also for reduction of cardiovascular risk in people with type 2 diabetes. However, prescribers can and do prescribe Ozempic for weight loss for people who don't have diabetes, and even though it's not on the FDA label. So that's considered off-label prescribing. And it's common for payers to limit coverage just to the FDA approved indications. And that's how the OEB coverage, or I'm sorry, how the PEBB coverage is structured today. So the carriers will cover Ozempic for diabetes, but they're not covering it for people without diabetes. Let's go to the next slide.
And Sarah, just a quick question. Yeah. Is the maintenance dosage on that previous slide, is it really the same for pediatric as for adults?
I believe it is because it's only approved in 12 and up. Okay. I can double check that and get back to you.
I just was surprised to see that.
Yeah, the maintenance, you can see down on the bottom under dose and administration. Yep, it's either 2.4 or 1.7, and 12 and up, it's also the 2.4 if they can tolerate it. Yep.
At that point, the body sizes are pretty similar to adult body sizes often.
Okay, thanks.
Yeah, good clarification. This is just an overview of the market in general. We've all been talking about Wegovy, and it's not the only GLP-1 drug out there for weight loss, but it's the one that gets talked about the most. There's Zepbound that was just approved in the last couple of weeks. It has the same active ingredient as Mounjaro, which is FDA approved for diabetes. There's Saxenda, that's an older GLP-1 drug for weight loss. It requires once a day administration rather than once a week. And it contains the same active ingredient as is in Victoza, which is used for diabetes. There's Contrave, that's a combination of bupropion, which is an older antidepressant, and naloxone, which blocks the opioid receptors. And that's believed to work on the brain to help reduce food cravings and food noise. Qsymia, that's a combination of phentermine, which you might recognize phentermine as half of the old fen-phen regimen from the 90s, and then topiramate, which is an anti-seizure drug that works to reduce appetite. And then there's just generic formulations of phentermine. Those are widely available, and those are still the most commonly used drug products for treatment of obesity. They're very low cost. They do come with some warnings and some side effects that are different than the GLP-1s, and they don't seem to work as well. But they are out there, and many of your members may have tried it because it is pretty low cost. They might be paying out of pocket. I want to note this is the beginning and not the end of the GLP-1 wave, right? There are dozens of additional drugs in development, including at least a dozen GLP-1s. There's also orally administered options. I think most of us that are working in this area, we're hopeful that with additional competition, it's going to bring down prices over time. That's not going to likely happen quickly, but it is going to happen over time. We're going to see reduced costs for these drugs in the long run, but not today, probably not tomorrow. Also, not on this slide, but I have to mention there's other drugs out there that are not FDA approved. There's supplements out there that are claiming they're going to stimulate weight loss. They have not been proven safe and effective, and they might be dangerous if individuals are trying them. And then there's also this growing industry of compounding pharmacies that are making custom versions of the GLP-1 drugs and they're marketing them at lower prices on the internet and elsewhere. These pharmacies are operating in I'd be generous to call it a quasi-legal space, but they're under limited regulation. There's been a lot of reports of contaminated counterfeit product. There was a report this week about a spike in calls to poison control centers driven by these compounded GLP-1 drugs. And so, I mean, for this reason, I would just never recommend them for a patient, for a friend, or a family member. But I also know people are doing it. And so I think the growth of the use of these compounded options, it does speak to that sense of urgency that people are feeling in wanting to try something new. And then at the same time being unable to afford the FDA approved options that are out there.
Yeah, so it becomes a bit of a safety issue then in the population.
Absolutely. Yeah, absolutely. If we go to the next slide, we've got a summary of some of the clinical considerations that we've been considering. Dr. O'Neill, did you want to go through these?
Yeah, well, I've hit on some of them, sort of the long-term safety. I mean, I think when I was on this panel here in Washington a couple weeks ago, the clinicians really stated, given the 15-year time frame of using these medications in people with diabetes, really gives them a lot of clinical experience with these. And so there are concerns and there are side effects. And of course, as more and more people use it, the side effect profile becomes clearer, a little bit larger, but they consider these quite safe drugs, people that are studying these academically and using them clinically. I think that the second point is both for kids as well as for anybody using this issue of having supporting services around the use of a medication to make sure that other issues that are contributing to the problem of obesity and are impacted by obesity are also addressed, I think are key to making sure the value of using these is maximized. The people I spoke with that are the clinicians in this world of obesity management were quite clear that they felt that when people stopped the medication, the likelihood of weight gain afterwards was quite high. Again, we don't have huge, long runways of supporting people with more intense programs, but that is a concern. And so I know that you guys have budgetary limitations, and so looking at getting people on this and keeping them on at the current prices, is daunting, and it's why so many organizations are hesitant at this point. We've also had some really bad stuff happening out there with intermittent supply disruption, and that's putting people into an on again, off again using situation, which is not therapeutically sensible in any way, shape, or form. So I don't know if Sarah has more insight into whether those kinds of manufacturing issues have been ironed out, but of course, with the introduction of more types of medications, there are more options for people, but you certainly don't want to have a stop and start problem with them. I mentioned the equity issues of helping people, particularly those impacted by this condition, which we know it is different in different populations. And then just we're going to continue to learn how this drug works for people for non-diabetic related obesity over time, and to figure out, what's necessary and what's useful, for people, and how well they're tolerated over time as well. I don't know if we have a whole lot of data on what it looks like to be on these things for 15 years. That would be the furthest horizon that we have at this point in time, and that wouldn't be that big a group of people. So, yeah.
Thank you for that observation and for this very thoughtful work. Do I understand correctly then that even though we have 15 years of experience with this class of medications, it's a pretty small subset of people who might have actually been on these medications for all of those 15 years, in which case the longer term risks are not nearly as well understood as the shorter term risks or lack thereof in this case.
Yeah.
Yeah, and I'd add too that it's the data we have is the use in people who have type 2 diabetes. It's a much smaller amount of data that we have for people that don't have type 2 diabetes and are using the drugs only for treatment of obesity. And I think there's there might be a 5-year trial that came out from the manufacturer of Wegovy in the last couple of years, but that's the longest we've got. And that even still is a relatively small population compared to the potential number of users in the US population who could be candidates for these drugs.
And as you know from studies, usually when there's a study, there's some selection criteria of who's participating. It's not all comers. And so, how is something experienced? How effective is it? What are the side effect profiles when it's all comers, if you will? You know what I mean? And improvement in a group of people that have type 2 diabetes can be looked at somewhat differently than people that don't have that underlying disease state, right? Because what do you call improvement in people that are already dealing with that diagnosis? So there are just a bunch of things that we need to be paying pretty close attention to. And between the sort of unprecedented PR campaign, if you want to call it that so many people know about this drug, and the percentage of the population it applies to, these issues are kind of unlike other things in medicine where there's a much more targeted group of people that would be likely to take any given drug. So the other thing, and I don't know if this is, Emery, if this is what you're going to talk about next. I know you guys have annual cost increase limits. And one of the issues that we see, and you heard from a lot of the public commentary, whether it was advocates for individuals with this condition, advocates for people treating this condition, is that there's a lot of upside potential to help people be in healthier body weight. There's a lot of impact that we see in some of these earlier studies on cardiac pathology. It could be in the obesity group without diabetes. It prevents the development of diabetes, all of these kinds of things that are positive. But the time horizon of the cost of the drug and the time horizon of the value of the impact is probably not the same 12 months. So that, from just a dollar figure, you know what I mean? It, not that it's not valuable and not that there isn't upside to using these medications according to current research, but it's just a different time cycle. Did I steal your thunder, Emery?
No, but Emily does have a question.
Okay.
Yeah, thank you. Yeah, thank you. This is super informative. I had a general question. I guess it's an equity consideration related to BMI. So to your point, Dr. Oh my gosh, I've lost O'Neill. Dr. O'Neill. I'm just curious, just a general question. How do these studies, how do they deal with BMI for Asian Americans? In all these studies, how do they account for that Asian American bodies tend to have lower BMI, but higher health risk, but with lower BMI?
Yeah, that's a great question. And I don't know that we have the answer for that, in anything I've read so far. And I don't know, Sarah, if you've seen that result. I know, and even the term Asian is too broad, as you probably know. Yeah, there's very different health profiles in different groups of people within that large category. But so there's that. There's, a lot of people that are out there talking about you can be at a BMI that doesn't meet the healthy level on the charts and still be healthy. So there's sort of both ends of that spectrum in the argument of like, are you dealing with somebody by a number or by their actual health status? So I haven't seen that research on people with certain health profiles but lower BMI. Have you, Sarah?
Yeah, in the drug studies, I haven't seen it broken out that way. It has just been based on BMI. But I'd also say I've seen an increasing number of just acknowledgments and recognition that BMI might be a good metric at the population level.
Yeah.
Trying to understand the overall risk of a population, but it's a terrible metric at the individual level, because there's individuals that have very high BMI that are metabolically healthy, and there's people who have low BMI that are not healthy cardiometabolically. And so the prescribing provider really needs to look at BMI as just maybe an initial flag of maybe we need to dig deeper, but also just look at the individual more holistically than just the number, because the BMI is problematic. But it's kind of the only tool we have right now.
Yeah, I just know a lot of Asian Americans get missed for diabetes screening, for example, because the BMI is lower, but they definitely have diabetes. They just, nobody knew it. So they never managed it because they fall under sort of, I think in general, the medical research studies are mostly white male bodies, right? Or I don't know. Hopefully that's improving and being more inclusive of diverse groups. But I know historically it's been more the white male research participants.
Yeah, I think that's an ongoing issue in many different categories of drugs. And, and I think we also need to recognize some of the problems of BMI where people who might have body types that generate a higher BMI, they might feel like they're being medicalized by the system when they're healthy. And so there's just so many different factors that go into it. But big picture, what we want to make sure is individuals are being treated as individuals and their health status being looked at holistically. They're not just a number.
So I think we can jump to the next slide, Rose, if we're ready to proceed. We've got about 10 minutes left, and I want to make sure there's plenty of time for discussion around potential cost impacts, coverage options, that sort of thing. And so I'll go through this slide somewhat quickly. Some of these points have been made in the discussion so far, but this slide really outlines some of the benefit considerations related to this this question around GLP-1 exclusions. Specific to plan design, expected utilization, that sort of thing. With this first bullet, there have been a couple of states that have removed the exclusion and then later had to walk that back due to higher than expected utilization and less cost. Obviously, that's an outcome that we'd like to avoid. With this next one, duration of therapy, Dr. Neal has made some comments around how this is sort of intended to be a chronic, a drug used in sort of a chronic way. And so is there a viable off-ramp for folks? That I think that picture, it sounds like, is still sort of coming into focus. The cost for these drugs is high, right? We've got new entrants coming into the market in 2024, but like Sarah said, we're skeptical that there's going to be, at least in the short term, a market adjustment from a cost perspective. And with this fourth bullet, this is a big one for PEBB that we've sort of started talking on a little bit more recently in this conversation, and that's the annual cost cap of 3.4%. That's an increase that in some years is difficult to achieve just on a status quo basis before we start enhancing the plan. And so when we revisit this topic, once we get into renewals, at that point we'll have a better sense for how status quo 2025 costs are coming in, to sort of provide a little bit more informed context for if it's viable and if there's funding to support removal of this exclusion. And then on this last point, the benefit, the pharmacy benefit through the PEBB plans is very rich. And so that could potentially create a little bit of upward pressure on utilization. Folks aren't, when they go to the pharmacy and fill this prescription, from their perspective, in terms of their out-of-pocket costs at point of service, it's not an expensive drug. It's the plan that is picking up the vast majority of those costs. And so just something to think about, and something that we'll talk about more once we get into those renewal meetings, in terms of if there are ways to adjust the plan design to sort of try to offset that dynamic a little bit. But that'll be for a future discussion. So with that said, I'm sure everyone is ready to see some of the cost impacts based on different utilization assumptions. And so, Emery, I will pass it off to you.
Sorry, a little bit of a kid emergency there. So, hopefully I won't have to go onto mute or take off the video. But so this next slide kind of shows the cost impacts, and we are showing big figures here. So because the utilization, the duration, and the costs are uncertain. Depending on how the benefits made, benefit set up, as well as the potential uptake, there could be a wide range of costs. So what we show here is essentially at the top line the total maximum cost based on 3 different options. One is basically covering it according to label with no lifestyle modification. So essentially we estimated about 36,000 people would be eligible, and using a cost of $1,300 per month, but actually a significant portion coming back in rebates, about $715. So that's about almost 60% rebates. The cost, if everyone used it, would be approximately $125 million, or 11.4%. We also show potentially reducing or restricting the usage to a BMI higher than what the label is. And as Sarah mentioned, that might result in rebates not being applied. And so while the total eligible members using it is lower, essentially cut in half, the cost is actually higher because the rebates are making up more than half of the list or the allowed cost for that drug. And then with lifestyle modification, we still have, based on the total members, 36,000 potentially eligible, but then the expected utilization, as you can see in the row below, it's actually going to be a little bit lower because with the lifestyle modifications, there's more requirements, and members may not want to go through all of the process in order to utilize the drugs in that case. But for these three different options, you can see the expected utilizations. We do provide a pretty big range for the initial without any lifestyle modification. The range is between 15 and 50%. And then with lifestyle modification, we did reduce it to between 5 and 25%. But even at those levels, we are still talking about essentially 0.5% to almost 6% additional cost. And that's using a 6-month therapy. And if it continues, in terms of the maintenance every year and the number of members who don't use it, this is an annual cost. If the members keep using it every year, this is an additional cost, which essentially, in some cases may be above that 3.4% limitation. But even at the low end, we are talking about using up a portion of that 3.4% for the drugs. The BMI 35 plus, we do show some utilization there. We don't recommend that because of the loss of rebates, but you can see the potential utilization there, and the cost does range from 1.3 to 3.8%. So generally, the cost of these drugs will potentially eat up a portion of that 3.4%, and it will be on an ongoing basis. And hopefully, as Andrew mentioned, we don't want to have these drugs opened up and then realize that the cost is being prohibitive, especially with the 3.4 limitation, and that other benefits or this benefit would then have to be reduced as a result. Andy.
Oh, so again, just to clarify, so this is based on the 6 months per eligible member each year. And I am not a math person, but does that mean these numbers would be doubles if they did have to be on there for a year?
Yes,
or if it was
but
chronic?
not everybody is going to be using that drug. As mentioned, there are side effects, and sometimes they could be significant for some people, so they may not use it as much, or maybe you don't want to inject yourself all the time, every month or every week, and so we don't anticipate that everybody using the drug will be using it for the entire 12 months, and so that's why we're currently using an average duration of 6 months in this case. But some people may be using it 12 months every year.
And Emery, isn't there some assumption too of just ramp up, right? If you add coverage on day one, not everybody's going to get coverage right away. So some people might start a few months later.
Yeah, exactly. And new members coming in every year, those members might not get, but yeah. Any other questions on this slide? Representative Nose?
Well, maybe it's not about this slide. Maybe, I'm assuming you have some ability to try to show maybe some of our other costs around obesity are foregone. I'm sure that's not the right word. Forestalled.
Yeah.
Aren't realized. Maybe you've got a slide that could show that potentially.
We have shown that in the past. I think, as Dr. O'Neill mentioned, some of those effects are going to be much longer term. So it's difficult to say. It's difficult to say yes of this. Let's just. I think
it's like if I treat your depression now, you will have. It's hard to know if it'll have a long-term benefit. Short term, it just shows up as a cost to the plan.
For depression, I mean, I think it depends on the condition. So in terms of obesity, I mean, there's definitely some, as Dr. O'Neill mentioned, there's definitely some cardiac, improvements, but you may be, let's just say 40 years old right now, and you're obese, but you're not going to have that heart attack until 55, right? So that's 15 years down the line. And this drug may prevent that from happening, and that's great. But unfortunately, we are looking shorter term in terms of the funding.
Yeah.
And when do those effects come in? And hopefully, it's sooner rather than later, but this is difficult right now to offset for those costs.
Okay, thank you.
Yeah. Okay, so the next slide shows a little bit more detail on those coverage options that we have there. So just talking about the different, according to labels, and it has the BMI, and then cover according to the higher and also with the lifestyle modification. There's also another option based down below, again, calling for deferring coverage for now and reassessing in 26, especially with talking about, Sarah mentioned the new drugs that are coming in and the pricing and all these other impacts that potentially there's could be better pricing, better idea of the safety, the equity concerns, that deferring and then getting that permanent lifestyle lifestyle modification, studying that and having people work on their lifestyle modifications, that could be beneficial over the next year to do that, to wait and to keep working on adding all the elements around basically getting healthier about weight and all these other issues. In addition to lower cost alternatives, the market's moving very fast in terms of, the additional drugs. 13, I think, was what you mentioned, or Sarah. So, as these new drugs come online, the pricing is probably going to get better. Right now, Wegovy's expensive, $13,000 a month, and some of these other drugs are coming in cheaper, and there could be a possibility as if we wait, the cost for those drugs could come down quite a bit, and that it's going to be more cost effective at that point if once those drugs come online. So that's definitely that's one of the potential coverage options. Andrew, Sarah, Dr. O'Neill, is there any other comments on that?
No, I guess my only, talking about equity and then talking about having lifestyle management support attached to the use of these medications to improve compliance, side effect management, and effectiveness. I think that there needs to be some attention paid to how those programs are built and are they taking into account approaches and trusted sources and whatnot for different groups of people. So, I think we can say lifestyle management, and it sounds really simple, but I think there's a lot of attention that needs to be put to that.
Yeah, and I would just add a comment onto that we have, I don't know if they've been scheduled yet, but there'll be a couple of meetings in January to sort of try to answer that very question and establish what some minimum criteria are for the lifestyle support vendors. And the idea is that if we can create that list of criteria in January, we'll share them with the carriers who ultimately would subcontract with these vendors, and then be able to report back to the board in February with the carrier responses to that. But yes, Dr. O'Neill, heavy emphasis on health equity when it comes to trying to design and understand what are the important criteria for lifestyle support. That will be a big emphasis. Yes, Christy, see you every hand up.
And I just want to share that we are, the health equity work group as well has us on our radar for January so that we can work in partnership with CIAO and what's going on in January. So we're on it.
Good. Not easy though.
No, not easy at all.
Yep. So the next slide does kind of just summarizes, I think what Mercer would say would be the two best options right now, potentially deferring and waiting for the market to mature. As Medicaid does not have this coverage, the studies that they're doing, I believe it's, I can't remember if it's HERC or who's exactly doing the study.
I think
but
it's
they're
DERP.
actually, sorry.
Isn't it DERP through OHSU? I think it's the Drug Effectiveness Review Project.
It could be.
Doing. Yep.
Yeah. And so it's actually their study is being delayed a little bit until the beginning first quarter of next year. So, they're kind of waiting and watching what OEB and PEBB does, and we're kind of watching and seeing what they're going to do. But they're not going to have a recommendation anytime soon. So potentially waiting for the market to mature is an option. There is, in terms of if coverage was to be offered right now, I think having that lifestyle modification vendor to make sure it's a holistic view on weight loss and addressing people, addressing every the needs of the people, and that it's trying to make it less of a long-term drug as possible. Getting that getting health in, and wellness total, and, achieving those, to your point, achieving those clinical outcomes a little bit sooner in this case. It's not just using the drugs, but it's actually using the drugs and getting better and getting healthier so that the longer term costs are reduced and that, the trend goes down and it's easier to meet the 3.4% in the future. But that's definitely, that's an alternative option in this case. I think this is our last slide. So I guess if there's any other comments or questions, Andy?
Sorry, once again. So I don't know enough about the federal system and whatnot, but with the Oregon Health Plan and Oregon Medicare, Medicaid, and like, if they're not covering it, are they looking to cover it? Are there, I mean, so because I just
Yes,
feel
there's-
like that's, there's a lot of pressure on us. But if you look actually at the socioeconomic, conditions of people who are obese, like that's really a population that needs to be addressed. And so I'm just curious, like, how that affects and like what they're doing.
Yeah, I can take that. So Medicare does not cover weight loss drugs. It's a statutory exclusion in law. There's a lot of lobbying going on at the federal level to, from manufacturers, from advocacy groups, from a lot of people trying to get that changed. But as of today, Medicare does not and is not going to cover them. With Medicaid, weight loss drugs are one of the few categories where Medicaid actually is given the option to cover or exclude. And I think there's about a dozen states now that are covering the weight loss drugs, including some larger Medicaid states like Pennsylvania and Massachusetts that have added them in the last year or two. Oregon currently does not, but they are, I think was mentioned earlier, they're looking at it, and they're working with the DERP group to explore coverage. As far as other public employers, we've seen a range there. A couple of interesting things happened recently. Iowa and North Carolina were covering, and the utilization was greater than expected, and they actually had to pull back on coverage. And so in 2024, they're going to stop covering when they had been covering before, and that's of course less than ideal situation. But we've also seen some other states add coverage, like Connecticut is adding coverage just with a lifestyle management vendor, and we've seen some other states move in that direction as well. So all this to say, it's really evolving in the public sector as well as it is in the private sector.
Great, thank you.
I just think, I mean, I know that there's a statutory issue with Medicare, but I think the categorical exclusion of any treatment for obesity, given the prevalence and the health impact, is unlikely to continue.
I think it's going to get interesting if the manufacturer of Wegovy submitted, so we saw their label earlier, right? So the manufacturer of Wegovy did a trial looking at the use of the drug for people without diabetes that had high BMIs for the purpose of preventing major adverse cardiovascular events like strokes and heart attacks. And they had some pretty good data come out of that. And so they have submitted for a labeled approval for prevention of what they call MACE. And if they get that labeled indication, I think it gets interesting quickly as far as whether or not Medicare can continue to exclude.
Ollie, did you want to comment?
Just thanks, Siobhan. Quickly, we started a kind of a subgroup within OHA made up of PEBB and OEB staff, as well as the Health Evidence and Review Commission, the HERC, and the P&T Pharmacy Committee staff. So I think as Zimri said, they were starting to look at holding hearings early next year, and they pushed that back. So, but we are staying coordinated with them. They're probably actually watching this meeting right now. So there's a lot of coordination going on with Medicaid coverage within OHA and with us, obviously. And obviously, equity is definitely something that we would all like to achieve here. That's it.
Thanks, Ollie, and thanks for defining the acronyms there, Dawn. So any other comments? Certainly a lot for us to digest. Emily, go ahead.
Yeah, that's great to hear that work group is happening. Ali in OHA. I was just going to add from an equity perspective, and one size doesn't fit all, as has been alluded to by many here. For the Asian American community in Oregon, I don't know if people are familiar with the 2020 census findings, but 34 of our 36 counties experienced an at least 25% increase in Asian Americans. And then some of our most populated, already populated Asian counties, Multnomah, Washington, Clackamas, like, I don't know, about like 40 to 60% increase or something like that. And then the middle of Oregon, over by Bend, like over 100% increase in Asian Americans. And so just, you know, the BMI, for example, and how Asian Americans tend to have lower BMI, but still be at risk for health conditions like diabetes or whatever. This would be a relevant issue to the state of Oregon. So just, you know, wanted to highlight that.
Thank you.
I haven't been able to dive in deeper, you know, with other communities, but you know, maybe others, maybe Mercer has, or others. I'm still learning myself.
Thanks, Emily. And so I just want to recognize for all of us, we will continue to have CL meeting to discuss this. I believe it was Christy who said this will come up at the health equity meetings as well. We had initially thought we might have enough data to make a determination December or January about whether we would offer the GLP-1s in a mid-year enrollment. The earliest we could consider that would be February. That's my understanding. And we're seeing a recommendation today that, you know, as things continue to change, we will continue to get more data in. The Medicaid data will come sometime, or decisions around this will come sometime late in the spring, right? Like maybe April, May timeline. So there's a lot for us to continue to look at. And we will be having an active discussion around this again in February. So I want to say that since no decisions are being made today. I do think we still have time to hear from Sharna on the PEB Wellness listening session. So I'm going to move us to that and then note all of the public comment that we have. So Sharna, I'm going to hand it over to you.
Thank you, Siobhan. Hi, my name is Sharna Freehan. I am a policy and program consultant with PEBB and OEB with a focus on health equity, and I use she, her, and hers pronouns. I want to thank the board for supporting this health equity work, and the presentation here should help to explain what we heard and what we learned during our sessions. Please feel free to stop me and ask questions. Obviously, I only have 15 minutes, so I hope I can get through it all, and I am open to coming back if we are unable to get to all the items that I wanted to share with you. I am presenting qualitative data, and all the information given is in aggregate format to ensure the privacy of those who shared their stories with us. So the basis of what we did was we offered listening sessions to employee resource and affinity groups across the whole, all of the agencies, as many agencies as we could identify groups for. We shared the book of wellness programs, all of the programs that PEB offers prior to the meeting, so we knew what the scope was that we were looking at. And we chose these groups because so often we don't get to hear from our members who are not part of the dominant culture. We wanted to elevate their voices and work at enhancing health equity. So we had Mercer doing the facilitation. They asked open-ended questions and got some details from folks. We had a counselor attend every session to support members in case they became activated or if trauma resurfaced. We had the members were assured that their agency-specific group wouldn't be named in any report out. We also committed to protecting the privacy and communicating the requests from the groups and reporting back results. Some groups participated via an anonymous survey as opposed to having a full listening session. So the results here are being presented as opportunities to enhance health equity and assist OHA in reaching their 2030 health equity goal. Next slide, please. So in the past, ERGs and affinity groups have given unpaid labor, including emotional upheaval during the labor, to let us know what's going on in their communities, and oftentimes have seen no results or even a response to what they heard or what they shared rather. And we were committed to doing better and to create meaningful engagement with our groups and have communication working both ways. So this is why I'm presenting this to you today, because they wanted to make sure that their ideas and their needs and their experiences were shared with the board. So we had 5 group sessions with, and 5 separate groups had surveys. So we had a total of 10 different groups that gave us feedback. And while you can't tell which specific groups we met with, some of the feedback will indicate, excuse me, a particular health equity need associated with that group. So while we can't tell you which group we met with, you will obviously know. So we'll be moving into the specific results. Next slide, please. So this is some general feedback that we can't get to health equity if people can't find our programs. And so we received information that folks were having difficulty finding or navigating the wellness webpage. They didn't know how to access all the resources on the EAP Canopy page. And there was even one individual who believed they had to enroll with Canopy EAP in order to use it. So there's a lot of confusion or even just lack of knowledge of the breadth of programs that are available. A lot of the participants didn't understand what aspects of the programming are PEBB decisions. So the number of available Canopy sessions is not a PEBB decision. Many felt that minimum provided number was much, much too low. They need more. Gym availability and safety parameters aren't directly under PEBB control, and there's a misunderstanding about the benefits that are available to all PEBB members versus those that are carrier specific, like Calm. So a lot of confusion out there from what I garnered. Some employees want to have more opportunity to participate, which included paid time. Obviously, that's not something PEBB can grant. They also asked that there be enough staff hired so that some members didn't feel overworked. And one example that was given to me was an individual who needed to take time for themselves after the George Floyd murder press coverage came out, and that arranging a time adjustment was just adding stress to an already traumatic situation. All right, next slide, please. So we heard commentary naturally about the most used programs. So we heard the most about those well-advertised Canopy that has a sticky in every office, that sort of thing. So these are the programs that folks know about the most and tend to use the most. So the issue with triage is there are several issues that were reported to us, but one was a person was misgendered multiple times during a conversation and decided not to use Canopy again. There were also reports of the operator not appearing to be listening to the problem or was distracted by a person's diagnosis. So one person had a missing elderly parent and they needed resources and they were not, connected during that time. Members also expressed the impression that they were being rushed to be transferred. I did have a brief conversation with Canopy about this, and they stated that they thought that this might be related to their after hours service that picks up the calls and that they didn't have any control over their diversity training or cultural competency measures. It would make sense to look a little more closely at this and at that member experience with both providers and just trying to evaluate what the experiences are dependent upon when they're calling. Diversity in the counselor network. Members shared locating counselors who identified as LGBTQIA+ or a person of color was very difficult, and the task was given to the callers. At least 3 members stated they gave up after searching and settled for less service or didn't use the service at all. They requested more sensitivity around trauma and the daily life experiences for LGBTQIA persons. There was some feedback on active and fit. It was reported that there were no safe changing spaces for transgender participants. They felt threatened or unwelcomed in the gym environment. And attempts to add a friendly gym were unsuccessful. Resources. Some folks reported that they need more end-of-life resources, ADA resources, resources for multi-generational caregivers, and all those seem to be absent from the programming, and multiple requests for culturally specific resources for persons of color, immigrant perspective, dealing with the culture shock. Next slide. Okay. I apologize. I lost my place in my notes. Opportunities. Oh, there we are. Okay. So some members would like a listing that shows folks concordant programs and staff, sort of a matching menu. And that included LGBTQIA, persons of color, and other languages and cultures. Multiple requests for multiple languages and cultures, including Spanish and Vietnamese. The workplace hate. So this is kind of a hot topic. Unfortunately, this was heard in multiple sessions. It's happening. This is an HR issue, but it's also a critical wellness need. One manager stated that the other managers in her office didn't have confidence that EAP could help in workplace hate occurrences. And another participant stated they had to be in crisis in order to get some assistance with workplace hate incident. So the wellness piece is enhancing that sense of belonging and safety and support around these events, and a better response protocol could be implemented. It also brings up the potential to coordinate with HR because sometimes an outside counselor doesn't understand the office culture or what they're stepping into when these issues come up. And so a partnership between that could bring a more holistic approach to the response process altogether. Moving on to Weight Watchers, they don't offer a Spanish app, and there's no reference to Latinx culture, was one comment. I researched the Weight Watchers website, and there are some Latinx pages and some that are translated into Spanish, but that was not the perception of our member. And the comment was, Weight Watchers did not address my culture or food practices at all. If Weight Watchers was to provide this, they would need to be skilled and culturally congruent. Weight Watchers has historically had problems with reach, and perhaps a more culturally well-rounded offering would likely increase their reach and be a better value to our members and the board. The last piece was functional fitness for all. There's an age discrimination factor that a lot of these functional fitness programs or aquatics are reportedly only offered to elderly members. So there were some folks that were not elderly that really would love to access them. Next slide, please. All right, so not everything was negative. Some folks wanted to continue with their EAP counselor, and there was a lot of appreciation for EAP. There was a lot of appreciation for EAP counselor, and there was some folks that were not elderly that really would love to access them. Next slide, please. All right, so not everything was negative. Some folks wanted to continue with their EAP counselor, and there was a lot of appreciation for EAP conducting a session with staff over a national racial incident, and more groups did request these types of supports. Canopy served family members as well as employees, and most survey respondents said they felt respected and included when contacting their wellness program, and most felt that the interaction met their expectations. However, this is not entirely in agreement with what we heard in listening sessions, so it was interesting that we had that dichotomy. Appreciation was expressed specifically for health coaching, Omada, and Canopy. Next slide. Okay. So the participants had a lot of ideas, and and these suggestions are directly from our sessions and our feedback on our surveys. So members are busy, and discovering what's available is on their shoulders. And from what we could tell, it's hard for them to make that time or to find the things. So, and a lot of times we have long-time employees that don't get the uplift your benefits. They don't understand that there's all this whole menu out there for them. Maybe consider doing a published recording that explains the wellness benefits versus a clicking and reading model. The uplift your benefits presentation was helpful, but it was perceived as long, and wellness is a short segment at the end, kind of like this. Let's see. So the suggestion was to include a separate module for wellness offerings as part of the Uplift Your Benefits presentation. They requested direct links and programs to the programs mentioned in the wellness newsletter, and share the wellness policies often, so that not only the employees know what the policy is, but the management as well. Folks wanted more connection and community around wellness programs to enrich the experience. And we thought that maybe wellness coordinators could amplify and assist in creating more local community. And we asked them about a dream program. And the dream program would offer true financial wellness that includes credit repair, lower mortgage rates. It was reported that the current program, while it has a discount, it actually costs more in the long run. Professional development and small startup business resources. It also would like to be holistic and have an easy touch. Next slide. So next steps. So this is part of our community commitment. We're going to bring everything back. If the board decides to take, I'm not asking for action today, these are just suggestions, but if the board decides to take some actions and make some improvements, then we'll be reporting that back to our groups. And creating real health equity is the hardest part. There's challenges to identifying specific actions to implement that actually garner that health equity change. And the identified needs are a direct result. These are directly from the voices. So some initial suggestions or food for thought. Request some safety assurances, especially in active and fit and Canopy triage. Increase provider diversity, which is a long game, but we need to get a real start. Consider reviewing EAP and backup companies' triage systems to ensure more culturally sensitive care and consistent service. Possibly partner with HR to address workplace hate and simplify the process to get in more on-site help. Encourage agencies to increase EAP free sessions, possibly by raising the minimum amount of sessions offered. And look to increase the number of languages offered in the programs. And one thing that I realized I missed in one of my other slides is there was one app that was reported as not WCAG compliant, and this was reported by one of our members who uses a screen reader. So encourage that compliance for all the websites and apps that we promote.
Can you remind what WCAG is, please?
Oh, you know what? I can't think of it off the top of my head because I'm ding dang nervous, but it is a set of standards that help visually impaired people access documents. So it's a standard that is put in place for screen readers and fonts and visual descriptions, that sort of thing.
Okay.
Thank you so much for your time, your attention, and your commitment to health equity. I really appreciate you squeezing us into your schedule.
Thanks, Sharna. I know you recognize this is at the end of the meeting, and a couple things I think would be helpful if you send the board the list of recommendations, the concrete recommendations, since they don't show up here on the slide deck. And it's just really helpful to have these voices brought to the meeting that we don't often hear from, right? Because we have smaller numbers of people. And I think it was recognized earlier in our agenda that often when we're looking at research around health, it's focused on, it's been more white male in the past, and how do we resource and get feedback from groups who we often don't hear from. So appreciate the sessions you've had, would appreciate those concrete recommendations. We are past time on our meeting. We do need to make space for public comment. I just want to give one moment to see if any board member wants to comment on this too before I move to public comment. So any comments for Sharna? Go ahead, Emily.
I just really appreciate you, Sharna, and your team for all your hard work in doing all these listening sessions and elevating those voices. And I love that idea of partnering with HR to deal with workplace hate. And just, you know, as the OHA Vice President for Local 200 SEIU, I'm in monthly meetings with the HR director and their team. So I can definitely, you know, bring it up at one of our future meetings.
Thanks, Emily. All right, so we do have a lot of public comment today. It's written. You have it in your packet. Sarah wrapped off all those groups for you. This is the most public comment I have ever seen. And it's also coming from national groups as well, not just folks here in Oregon. We did have a manager from the Treasury Department write us. Other than that, it's groups that are represented. I jotted down who they were: Oregon clinicians managing patients with obesity. They weighed in. The Obesity Action Coalition, based in Tampa, Florida, weighed in. PILMA, the Pharmaceutical Industry Labor Management Association, that works with building and construction worker unions, weighed in. Their Oregon representative wrote the letter. We have the National Consumer League in Washington, D.C. We have AFPA, Alliance for Patient Access National Network of Healthcare Providers. And we had the American Diabetes Association, and they included a long article for us to read. So I believe that was, wraps down the list of folks. We can all take the time to read that public comment. I just really want to appreciate Mercer's presentation today, because I do feel like they covered much of what was covered in public comment and referenced it as well. Certainly, I know that all the board members take chronic disease management very seriously, and we are all considering the use of GLP-1 drugs for weight management, and we need to see continue to have the discussion, see the data come in. Obviously, we have the 3.4% limit imposed by the legislature around it. So, we have a lot of competing issues here, and we also have public testimony from legislators in November, as well as, I believe it was the AMA. Sarah referenced that too when Mercer spoke with us. So highlighting a lot of public testimony. This will continue to be a discussion for us. I don't believe we have anyone that was planning to speak publicly, but I want to pause and make sure that's the case. Rose, did we have anyone sign up to speak?
I don't know of anybody who wanted to speak. It was mostly written.
Okay, great. All right, so again, all of that's in your packet. Appreciate everyone's full attention here today. I know we had a couple people hop off for other meetings. I do want to wish everyone a safe and happy holiday season. So thank you all, and we are going to officially adjourn today's meeting. Enjoy the holidays.
Happy holidays. Thank you.